Do you have a serious long-term health condition? Then make sure you double your defenses this winter with the COVID-19 and flu vaccines. Extra protection is critical, as flu and COVID-19 can make you seriously ill. It's safe to have both vaccines at the same time, so don't delay. Do it now. Double your defenses. Get vaccinated, get protected. Go to nhs.uk to find out more.
This is Our People podcast, telling the stories behind South Tyneside and Sunderland NHS Foundation Trust.
Hello and welcome to this episode of Our People podcast. My name is Fiona Thompson and I'm a Communications Officer with the Trust. I'm really pleased to be here today with Professor Colin Rees and Ingrid Emmerson because this week marks Colorectal Cancer Month and that's all the way through March. Bowel cancer claims the lives of 16,000 people in the UK each year, and it's the second biggest killer following lung cancer. Thank you for joining us, Professor Rees and Ingrid. Would you mind starting us off by introducing yourself, Professor Rees?
So yeah, my name's Colin Rees. I've been a consultant at South Tyneside and Sunderland Foundation Trust since 1998. I'm currently employed by Newcastle University. I actually moved to being employed by the university about 4 years ago. So I do my research work at Newcastle University, I do my clinical work, and we recruit a lot of our clinical patients from South Tyneside. So over the last decade or so, our trust really has established itself as one of the leaders in the world for research in colorectal cancer, particularly the early diagnosis part of it, prevention of it, and screening for it. So it's really good to be part of this podcast today and tell people a little bit more about bowel cancer and about the research that we're doing. I should just say that bowel cancer and colorectal cancer, I may use those words interchangeably. Colorectal cancer is the technical term, but bowel cancer is the term that lots of people use.
And how does your job work in between both organisations?
So I spend the majority of my time at the university, and I do endoscopy, so that's telescope examinations of the bowel at South Tyneside, and I do clinical research at South Tyneside.
Ingrid, would you like to tell us a little bit about your job and how you became a research nurse?
So my name is Ingrid Emmerson and I work as the delivery lead for the COLO-SPEED project. The COLO-SPEED project was developed about 4 years ago now, and COLO-SPEED stands for, the COLO part of it is colorectal, and the SPEED part is for screening, prevention and endoscopy and early diagnosis of bowel cancer. So it's basically based around bowel cancer. So I started work as a nurse in January 1995, and I did train at Newcastle, and my first role was in theatres. I used to work in theatres there. And it was just basically a conversation with one of the surgeons during a coffee break, as you do. And he mentioned that he had a prostate cancer study and he was looking for somebody to support that, a clinical nurse to support that particular study. That was in 2000, and it was a secondment for a year initially, and I basically never went back after that, so I enjoyed it so much. So I've worked predominantly in Newcastle, and I came to South Tyneside about 5 or 6 years ago, and then the COLO-SPEED project came about, and I met the criteria for the project, so I applied for the position, and I was very fortunate to be interviewed and be successful in post.
And so we're going to be talking quite a lot today about some very similar named things. So we're going to be talking about COLO-SPEED, which you've already touched on, and SPEED is an acronym. And so then we've also got COLO-Cohort and COLO-DETECT. So would you mind explaining a little bit about what each of those things are?
So the COLO-SPEED project has a number of studies that sits underneath that. The very first one that came about was called COLO-Cohort. So COLO-Cohort is really quite a big number study, so we're going to get 10,000 patients into one of the cohorts and 10,000 patients into another cohort. Cohort just means group. So we're looking to develop a risk stratification tool so we can fine-tune colonoscopies for the future. So colonoscopy, it's quite an undertaking to have that particular procedure done. So we want to try to target it to those patients who would require that procedure particularly. So it's basically gathering lots of data sets, data fields, from people who are having a colonoscopy and looking at the results of the colonoscopy and comparing the two. So it's lots of different data sets, things like family history, comorbidities, current medications, blood test results, stool test results, etc. Gathering all of that data from 10,000 patients in order to develop this risk stratification tool for the future.
Another important part of it is looking at the microbiome. Lots of people will be aware that the bugs that live in the gut are important. You'll have seen adverts for things to change the bugs in the gut, and we call this the microbiome. The microbiome is a really important factor in many diseases, and definitely within bowel cancer and colorectal cancer. So one of the main elements of COLO cohort is also to look at the microbiome. So we're looking at multiple factors, as Ingrid's just said, around risk factors for bowel cancer. I think it's probably important to say at this point that bowel cancer starts as pre-cancer, and we call those polyps, and it probably takes about 10 or 15 years for polyps to turn into actual cancer. So a lot of our work is actually around finding those and preventing people getting bowel cancer in the first place. As everybody will realise, preventing cancer is much better than actually finding it and curing it. Both are clearly very important, but most of our work is in the finding it early or preventing it place.
And in terms of these studies, Colin, you do the procedures?
Yeah, so
your team does?
Yeah, so there are a large number of colonoscopies here. I do quite a lot of colonoscopy. So colonoscopy is where you put a tube into the back end and have a look around the bowel. So most of our research is based around colonoscopy. That's where the COLO comes from. We've actually got a whole load. We've got COLO-FIT, we've got COLO-LIFE, we've got COLO-SPEED, we've got a whole load of COLOs. I should have said probably when I introduced myself, even though I'm in this trust, I'm a Newcastle United fan, and I'm desperate for us to find a Coloccini who was a player who used to play for Newcastle. So the team there's a reward out there for whoever can find a Coloccini study.
That is an award to win, isn't it? And I guess, Ingrid, you help compile all the data when you put together the information that Colin and other members of the team gather when they're doing these procedures.
So for COLO cohort, we are sponsor for that study. So South Tyneside and Sunderland are sponsor for that study. We don't have sort of 10,000 patients locally, so what we do is we open that study out to other sites across the UK. So for COLO cohort, we've actually got 30 trusts across the UK at the moment, so from as far afield as Glasgow down to our colleagues down in London area, etc. So we've got 30 studies open to COLO cohort, and each of those we actually manage to make sure that they're doing our research to all of the rules and regulations that research follows. So we do sort of training with the delivery staff. There's an awful lot of training and ensuring that the data that they provide for us is in a certain quality as well as the quantity, and ensuring that we get good quality data from each of our sites so that we are able to answer that research question effectively.
So it's just making sure that all that work isn't going to waste and everything's it meets the standards that are required.
Awful lot of work, very high standards.
So essentially we lead lots of these studies. I mean, pretty much from our trust in partnership with Newcastle University, we lead the largest studies in this area in the world now, and have done for the last few years. We've probably recruited around 20,000 patients to our studies over the last few years, with, as Ingrid's just said, another 10,000 at least lined up and another study just about to finish. So clearly the most important part of all this research is the benefit to our patients. It's actually improving the outcomes for them. It's increasing knowledge for the wider community, but I think it's also incredibly important reputationally for our organisation. We're seen as a world leader in this field, and if people, from the United States, from Australia, from the Netherlands, all over the place will know of South Tyneside and Sunderland's work because of our research.
And you've already mentioned you follow Newcastle United, and we should mention that the Sir Bobby Robson Foundation supports the COLO-SPEED project, so I don't know whether you want to tell us a little bit more about how that works.
Yeah, Absolutely. So the Sir Bobby Robson Foundation, as people would know, is a charity that he established when he was alive. He tragically died of bowel cancer, I think it's about 14 years ago, I think it was 2009. And that charity has continued and has grown into a really important North East charity since his death. They fund a wide range of cancer research, and around 3 years ago they funded the COLO-SPEED work. They gave us around about £1 million to do that work. COLO-SPEED is essentially the infrastructure under which all the other research studies run. So there are many elements of it, recruiting patients, but also building a big digital platform that allows more recruitment on an ongoing basis. So we're incredibly grateful to the Sir Bobby Robson Foundation, who are our partners, and we're due to go to them in a few weeks' time and present an update on our research to them.
Brilliant. And that's obviously something very well known in the region, also across the football and community.
Yeah, absolutely. I mean, I think Sir Bobby Robson is somebody who was respected, maybe slightly cautiously by Sunderland fans, but was respected
He's
throughout.
He's still a North Easterner
yes,
through and through.
Throughout the football world, and huge amounts of really good charity fundraising goes on throughout the whole of the North East. In fact, through the whole of the country, but predominantly in the North East. And I think that's really important because we do know that many of the national cancer charities, which I'm not going to name, have a significant bias towards what we call the Golden Triangle, London, Oxford and Cambridge, in terms of funding their research. So I think it's really important that we have strong funding in the North East that actually keeps that money within the North East and funds research in the North East.
And I guess when people see runners going past them in the Great North Run, or they hear about a fundraising event, that's where your money's going, and that's the difference it makes.
Yeah, absolutely.
Fantastic. We've also touched on COLO-DETECT, so would you be able to tell us a little bit more about what COLO-DETECT is all about?
So COLO-DETECT is what we call a randomised controlled trial. So that's where you actually randomise patients to have one thing or another done. It might be to have a drug or not a drug, it might be to have an operation or not an operation. In this case, everybody who's coming for a colonoscopy is offered the chance to be part of this trial, and they are randomised to having the colonoscopy with or without this technology called GI Genius. And GI Genius is an artificial intelligence system. What we do when we do colonoscopy is we look at the lining of the bowel and see if there's abnormalities. But we know that human eyes are flawed. So the GI Genius system is an artificial intelligence detection system that enhances images and looks to see things that we don't see. So what it does is if it sees something that it thinks looks like one of these polyps that we talked about, it puts a green box around them and encourages the endoscopist to have a good look. It doesn't tell you what it is, but it tells you to look at it more thoroughly. So we believe that will improve detection at colonoscopy, but we don't know that. So what you do is you do a trial to see. So we require 2,032 patients from 10 centres for this trial, and we are at 2,010 patients today on the 1st of March. So we will complete that trial this week. It's been a pretty significant undertaking, undertaken by Ingrid and many others in our fantastic team. Been particularly challenging doing this trial as we've come out of the pandemic, because as we all know, the pandemic has changed lots of ways medicine's delivered. Lots of our prioritisation has gone towards things like flu and COVID, so actually getting this prioritised has been quite difficult. So it's been a fantastic job. It's probably been the hardest study we've ever delivered because of the pandemic, but to actually get here is incredibly satisfying. So we should have the trial complete, as I say, this week, and it will then take us probably about 3 or 4 months to analyse the results, and we're hoping to have the results of that trial widely available by around June, July of this year.
And so we're recording this episode a little bit ahead of time, so by the time this goes out and people are listening to it, that work will already be beginning to pull that all information all together.
Absolutely.
Start the analysis.
Yeah, the trial should be complete round about the 1st of March, and we will we should have the results round about late spring, early summer of 2023.
What then happens to that research? What do you then do with it? What's the action at that point?
So we will publish it. We are working with a commercial partner in this, the people that make it, so they will clearly be very, very interested in the results. We'll present it at medical meetings, and we will, if the trial demonstrates that the device works, and I say that's the whole point in doing the research, to find that out, then we will disseminate that information and get adopted into practice. There are also routes like NICE, National Institute of Healthcare and Clinical Excellence, that endorse and support things. We've done previous research on something called the endoscopy vision, and NICE endorsed and supported that to the extent that NHS England paid for rollout of it. So I think our research has really far-reaching consequences, because you're absolutely right, there's no point in doing research, showing something, and then people not adopting it. One of the hardest things to do is to get doctors and other practitioners to change their practice based upon evidence. So we develop the evidence, and then we try and get the message out there as to how to change your practice.
And when we're talking about AI and GI Genius, it's a box. It looks a bit like to a layperson like me, a box like a games console, or like a DVD sized box that goes on top of your kit.
Yeah.
So you wouldn't necessarily know anything as a patient, I don't think necessarily.
So as a patient, you wouldn't know any difference whatsoever. And I think it's also really important to say that the box is not making the decision. The box is assisting the colonoscopist in making that decision. Artificial intelligence is now used very, very extensively within healthcare. If you take, you could have a radiologist sat looking at x-rays all day. Towards the end of the day, they're bound to get tired. They may miss things. So they're actually using artificial intelligence now to say, look, have you checked that area properly? That kind of thing. Artificial intelligence is in all of our lives. We may not know it. All that we do, phones, everything, artificial intelligence is there, finding out what we're doing and interpreting it. The interesting thing that computer-assisted diagnostics have been of huge interest for a long time. But historically, what we tried to do was teach machines what to do. Artificial intelligence works differently. It spots characteristics of things. The way the light looks in the bowel is different on a normal bit and an abnormal bit, and it then teaches itself by doing things over and over and over and over and over again. We call it neural networking or deep learning. That actually, and the other interesting thing about it is that carries on. So even if you have something that's approved for use, it will carry on learning. So it may be 99% accurate, but over the years it will go 99.1, 2, 3, 4, 5 and get better at picking things up.
And when we talk about the green box, because I think I struggled when I was writing about this in my role, you have the screen that shows what your camera is picking up within your patient,
Yep.
but then it literally draws a green box,
Absolutely.
a bright green box that highlights a little spot
Yep.
that basically suggests that you go and investigate that a little bit more.
Yeah. If anybody's ever watched Sky Sports, as you might have guessed I would as a football fan, you'll have the situation where they may have the football match up, and then one of the pundits draws a ring round a football and says, he's playing him offside.
Look what he's
kind
doing,
of thing.
yeah.
That's exactly what it's like. It draws a ring round it and draws your attention to it. The person undertaking the procedure then looks at it and says, yes, that is an abnormality, or no, actually, that's picked up something that's not an abnormality, and then makes a decision what to do with it.
And as part of this episode, we'll share some images as well, so that people can understand a little bit more about what that actually looks like to anybody looking on. And so I guess my next question is, what symptoms would a patient come to us that spark a further investigation? So what would people necessarily go to their doctor to be worried about, or what might be flagged up?
So if you were to see any blood in your stool, you definitely go and get that checked out. Any change to your normal bowel habits, so we're all different, so it might be what's different for you as an individual, so go more often or go less often. Sometimes needing to strain after you've been to the loos, if you need to go to the loo again. Losing weight unintentionally is something that you should get checked out. Pain in your abdomen or in your back passage, or signs and symptoms of anemia, which is tiredness and breathlessness. So if you've got any of those symptoms, the first port of call would be to go to your GP to get those checked out.
And it'd be quite hard for some people to take that action because they might be worried. I mean, your immediate kind of worry would be cancer, but could it be other things as well? And does it just really need the experts to get involved.
It does. I mean, the most common reason for blood in the stool is hemorrhoids or piles, so that's fairly common. So, don't need to panic, but definitely do get it checked out. So if you go to your GP, he or she will probably do some blood tests on you, might do a physical examination, etc. And if they felt it was necessary, might send you for a colonoscopy, which is either done here at South Tyneside or at Sunderland, which are both fantastic units. They're both purpose-built units, state of the art, and the staff are absolutely brilliant here as well. So absolutely get it checked out.
And you deal with this all day, every day, so it's not out of the ordinary for you. People might feel a little bit embarrassed, but really, everybody in this team, and I know at Sunderland, make everybody feel really welcome and relaxed, and take them through the process really well.
Absolutely. This is not something to be embarrassed about. It is what we do, and we're not embarrassed about it. We don't want you to be embarrassed about it. The other important area to mention is screening. The Ingrid has mentioned how people might present with bowel cancer symptoms, but the other, between the ages of 56 and 74, we actually do population-based screening. So any females listening to this will be familiar with the breast screening program and the cervical screening program. There aren't any screening programs for cancer for men at the moment, but bowel cancer is both men and women. So essentially every 2 years, people are invited to submit a stool sample which is tested for blood. Well, they actually don't. They dip a small stick in a stool sample and it's tested for blood, and if that shows up as having blood, they come for a colonoscopy. So the two routes really to colonoscopy are through your GP if you have symptoms, or through the screening program. But it's really important that people are aware if they have symptoms in the bowel, but also that they take part in screening programs, because screening programs find cancer much earlier and save lives.
And when people do come to us for an investigation, what happens when they come through our door?
So if they've been referred for a colonoscopy, they may well have a pre-assessment if that's felt necessary. But there's a little bit of work to do before they actually get here. So they'll be asked to do sort of a low residue diet initially, and then take sort of strong laxatives, because what the colonoscopist wants to see is they want to see the lining of the bowel, and the best views are when that's nice and clear. So they will be given some bowel preparation to take before they actually get here.
And what's in a low residue diet? What
It's
can
all
people
of the
look forward
things
to?
It's sort of white bread and chicken, eggs, that type of thing. So it's nothing with fibre or nuts or seeds or anything. And
so it's lots of the things that you
shouldn't do.
That you're when you're encouraged to eat more fibre and things, it's things like brown bread and whatever. It's important not to eat those in the build up to a colonoscopy, because we need the colon to be clear.
And it just makes it a much better process. Process is probably the wrong word, but that procedure.
You can't do it if you can't see. Basically, it's all about having good views. So, bowel preparation is a really important part.
And so, if somebody's come for an endoscopy, what happens following that procedure? What happens next?
So when they come for the procedure, when they arrive, they will be assessed by somebody, just check other medical issues, etc. And there are really two options for the procedure. You can either have it with or without sedation. We used to give everybody sedation, but actually that balance has changed, and at least 50% of my patients don't have any sedation at all. Procedure can be a little bit uncomfortable, but it shouldn't be downright painful, but it's entirely patient choice. The advantage of not having sedation is you can drive home, you can go back to work the next day, etc. If you've had sedation, you can't drive or operate machinery or do anything, sign legal contracts or anything for about 24 hours. So people come, they get assessed, and they go into the procedure room, and a colonoscopy generally lasts about 30 minutes. Depends a little bit on how tricky it is to get round the bowel. And obviously, if you find things like polyps in the bowel, we remove them at the colonoscopy, and that clearly takes longer. And then afterwards, people then stay in the department for about an hour just to make sure that they're okay afterwards, that they're feeling fine, and then go home. We know at the time whether we found anything serious, so if somebody has a serious diagnosis such as cancer, we would normally tell them. And if there's polyps, we have to actually send those off to the laboratory to be analysed as we would samples from a cancer, so it can sometimes be a week or so before we have confirmation of what we did. But we give people a pretty clear picture before they leave of what the colonoscopy showed.
And that must be quite upsetting and daunting for a patient sometimes when they're coming in thinking it could be bad news, or other times they're worried about it and it actually turns out that they're in the clear.
I think the most important thing to mention is the overwhelming majority of people who have a colonoscopy do not have bowel cancer. The overwhelming majority, even among screening, at least 90% do not have bowel cancer. But clearly if they do, it's very important that we manage that properly, and we tell people very gently that news. And the other thing about bowel cancer is that most forms of bowel cancer are very treatable by surgery, etc. So it's really important that we're very clear with what's happening, give people a clear message and a clear plan. Management of people who unfortunately do have bowel cancer is very, very good here. We've excellent surgeons, we've superb colorectal cancer specialist nurses. We get people through all the stages very, very quickly and operated on, if that's the appropriate thing, or other treatments very quickly.
And is colonoscopy the kind of only way that it can be diagnosed?
Or
other conditions could be diagnosed?
So colonoscopy is what we would call the gold standard investigation of the large bowel. We often do, when I mentioned screening earlier, I said that we often test the stool for blood. If patients have symptoms, we often do that now as well to actually see if there's blood in the stool, because we know that if there's no blood in the stool, the likelihood of anything serious being found at colonoscopy is very small. We're actually leading some national work called COLO-FIT at the moment, which is all around establishing the role of those tests in patients with symptoms. But in terms of actually looking at the bowel, colonoscopy is the best way. You can actually do CAT scanning to look at the bowel as well. What it does is it recreates an image of the bowel through the CT, the CAT scanner. It can find things, but what it can't do clearly is take samples from them or remove the polyps that I've talked about. So it is used in diagnosis, but it's probably it's the second choice test from colonoscopy. You might use it in some people if you thought they had a particularly difficult colon that would be hard to get round, or if somebody might not tolerate colonoscopy. But colonoscopy done well by good colonoscopists should not be a difficult procedure.
And we've mentioned polyps a couple of times, so I don't know whether to our listeners you want to describe what we mean when we say polyps.
So if you take the bowel, it's normally a flat piece of ground, like a flat piece of ground. Polyps are like little mushrooms that grow in the bowel, and over a long period of time those mushrooms can get bigger and bigger and turn into cancer. It's really important to say not all polyps turn into cancer, but almost all cancers did start life as polyps, and that process probably takes about 10 to 15 years. So you can imagine that there's actually quite a long window there to find those polyps and remove them. So we do research in terms of preventing them ever starting in the first place, things like diet, lifestyle, obesity, medication, and then we do work on finding the polyps earlier to actually prevent them getting bigger, because if you remove them they're gone, and then we do work on finding cancer earlier. So our work is at all stages of that process.
And I know we're talking about colorectal cancer month, but what other conditions can be found when you're doing these checks? Does it help you work out what else might be going on that could be causing these symptoms, or by chance come across other things that can help a patient manage their symptoms?
So sometimes they can show diverticulitis, which is a condition of the large bowel where there's kind of scarring, and that can cause some of the symptoms that were described earlier. And there's also autoimmune conditions as well, so ulcerative colitis and Crohn's are two autoimmune conditions which can affect the large bowel.
Yeah, so we use it for pretty much diagnosing everything to do with bowel. Our particular research interests are about bowel cancer, but it's the main investigation for other things, and the main ones are the ones that Ingrid just mentioned.
And because we're talking about COLO-DETECT, and I know the study is still going through that phase where you're working out what you found, but are you able to say what kind of benefits or what difference you think it's made so far, or is it just too early to say?
So I'm going to give the scientist's answer to that.
Oh.
I think we have to wait and see. If we knew that, so I believe it will improve detection in the bowel, but if we knew that, we wouldn't do the trial. So the trial is there to see whether it works or not. I think you may have an opinion, but it's really important that you approach it completely objectively. I think it will increase detection, but the trial will show us whether it will or won't.
kind of definitive answers come through that?
Yes.
Great.
Yeah.
And GI Genius as well, they're a company that have created this piece of kit.
So it's actually manufactured by a company called Medtronic, which are a really large biomedical company. They make ventilators, so that they contribute a significant amount during the pandemic. They make quite a number of pieces of medical equipment, and this is one device that they
make.
produce.
So Medtronic are the company, but GI Genius is the piece of kit.
Yes.
Just to get that straight. And we're also leading on COLO-DETECT. It's our study. We are in charge of it.
Yeah.
So what does that involve as the kind of lead trust? And I know you've already touched on already what you do to help support those other trusts that are working alongside, but how do you then pull all that information together? That sounds like quite a task.
So we have what's called a remote data capture platform that we use. So it's just basically a huge sort of database, and for COLO-DETECT that's called Macro. So when a patient is recruited onto our study, they're given, because of data protection, they're given a unique study ID, so it's pseudo-anonymised. So it might be ABC123, for example. So each site will then put the findings from patient ABC123 onto this database. They'll put on all of the data fields, and then we work with a clinical trials unit called Emmerson, and they've sort of developed this software around the macro system in order for us to be able to analyse the data that's coming in. So it's all pseudo-anonymised. But as for a sponsor for a study, again, we have to make sure that all of our sites are doing things correctly according to all of the rules and regulations, for which research has very many, and ensuring that the quality of data that's coming in is correct, so that the data is in the right format, so that we're able to do that analysis and get some good quality data at the end of it. Yeah.
And we previously talked to our head of research, Claire Livingston, and she
Right.
talked a little bit about how trials work, and that was really useful.
Yeah.
But they have to be very ethical, so we can't persuade somebody to take part.
Absolutely not.
We just have to invite them and give them all the information, and they go away and have a think about things, and you take it when they come back to us and say, actually, yeah.
Yeah.
I think it's also really important to say that research is absolutely a team sport, that although a study like COLO-DETECT is led by myself and my colleague at Newcastle University, Professor Linda Sharp, there is an absolutely massive team of people involved in it. So Ingrid's mentioned Enworth North Wales Clinical Trials Unit. They do a lot of the administration of the study for us. They do what we call the randomisation, that decides which arm you go in. That they will analyse the data for us. So we work with them. We work with other colleagues at Newcastle University who work on various elements of the study, and then we have the national delivery team, which is from South Tyneside and Sunderland Trust, which is people like Ingrid, Alexander, our research fellow, Claire Livingston, you've mentioned. So they coordinate it, and then we have local delivery teams at around 10 sites, and one of those sites is South Tyneside and Sunderland, but we have around 9 other sites, and that includes Newcastle Hospitals, they're one of our sites, Northumbria is one of our sites, North Tees and Hartlepool is one of our sites, as is James Cook in the northeast, and then we have a number of other sites throughout the country, which include Wolverhampton, Kettering, Morecambe, Bolton, and a site in near Watford. So it really absolutely is a team sport, with local research nurses in each of those sites and local endoscopy nurses being very, very important. But the most important people in all of our research are our patients. We cannot do research without our patients participating in research. Research is for patients to improve patient care, but unless we have patients who are prepared to be part of research, then we can't deliver it. But I think research is incredibly important to NHS organisations. We know there is very, very good evidence for this, that research active organisations deliver better care. That's been proven. So the fact that research is going on means that patients are likely to get much better care given to them, so we all benefit from doing it.
And we can't move forward unless we know
Absolutely.
how things can be made better.
Absolutely. But if there's one message I would want to give over and over again from this podcast, it is our gratitude to our patients for being part of research. We can't do it without them.
Yeah. I'm going to ask you some more questions about how we deal with our patients, but I will just give a special shout out to Alexander, who you mentioned there.
Yes.
Alexander Seeger, who is one of your team, really lovely
Yeah.
colleague of ours, and also he appears in one of our other podcasts because he is also a reservist.
Okay.
So he is super busy,
So-
but that's a really good listen, and he speaks really well about how he manages that in addition to everything else he's got on.
Yeah.
So Alexander saw the light and realised that it was better to come up and work in the northeast than work in Cambridge. So he came up and joined us because of our research. He contacted us and said, do you have research I can be part of? And he's done a brilliant job in delivering this study along with Ingrid and Jill Effard, our local research nurse here, and others, the whole team. You know, I could shout about all of them. Amy Burns is another person who does a fantastic job in coordinating our research, as does Nathania Bestwick, our COLO-SPEED coordinator. But there's never been a more difficult time, as I said earlier, to deliver research than after the impact of COVID, and they do an absolutely brilliant job.
And I know everybody here at the team, whenever I've come through the doors, have been really lovely and welcoming, and you can tell it's a real kind of family feel, and everybody keeps an eye out each other, and I think our patients probably really pick that up, because as an outsider you totally see those relationships and the work that you're all doing together.
One of the things I think we should really try and do in this trust is actually develop research in more areas. This gastroenterology is probably the area where we lead national research more than any other. The eye infirmary do a lot of research as well. In many others we deliver research but we don't lead it, but actually I think it would be really good for us to try and lead research in more areas, because I think once you develop that culture, everybody is interested in learning more and doing better, and as I say, I think it provides better care for patients.
And Ingrid, as a research nurse, I guess your career took a different turn that you didn't see coming, and you've really made it your own and helped make a difference that way. Yeah. And so we touched on our patients there, and we're really grateful for all the support they give us in putting together this and other trials. But when they are invited to take part in this, how do they react to that, and what process do they go through?
So we'll have a look to see if there's a patient that might be suitable for one of our studies. So for each of our studies they have what's called inclusion and exclusion criteria. So what you want to make sure is that the patient is suitable for the particular piece of research that you want to be doing. So what we usually do is we'll contact the patient, we'll say, you're coming in for a procedure with ourselves maybe next week. We're doing some research for people who's having that particular procedure. Is that something that you'd be willing to know a little bit more about? And we'll leave it very open at that. And the patient will either say, gosh, I've got too much on, I need to get the dog looked after, whatever. And you say, no, that's absolutely fine, as long as you're aware we're a very research active trust. You maybe you could help us at some point in the future. Or they could say, well, I could be interested, it just depends, what do I have to do? And sometimes people have a misconception about what taking part in research involves. They might think that they're coming backwards and forwards for the next 2 years for lots of visits to hospitals, etc. So we kind of need to work with them to dispel that myth and just sort of explain exactly what would be involved should they wish to participate. We'll give them a verbal explanation of what's involved, but also back that up with a written explanation as well, called a participant information sheet, which is all ethically approved, etc. And even when they've done all of that, they're still able to say, actually, it's not for me, and that's absolutely fine. And we are sort of guided by our ethics committees about how long they should have that information for in order to make an informed decision.
And I guess the brilliance of this piece of work is actually a patient wouldn't know anything different when they're coming for the procedure, because it's a piece of kit that's
Absolutely
added to everything else.
Yeah, they would not know. I mean, unless they'd seen a colonoscopy before and you knew that there's not normally a green box round things. They
I think you'd have to have a really keen eye to spot that, though.
Yes, they absolutely wouldn't know. It certainly does not do anything to make their procedure more difficult or worse in any way.
And do they know after their procedure's been done that the GI Genius has been up and running?
So,
or do you not tell them at that point?
So in an ideal world, we do something called a double-blind randomised controlled trial. That's where, placebo-controlled, that's where if you're taking a medication, neither you nor the person prescribing it to you knows whether you've had the drug or placebo. Clearly we can't do that here because blinding means you don't know. We know whether the device is on or not. So we don't specifically go and tell patients, but if they ask us, we answer them because it's there. So it's kind of a slight flaw in this kind of research that it's not the perfect research but you can't possibly do it any other way. It's like surgery. You can't be blinded to know whether you had an operation or not. You kind of know whether you had one or not.
Yeah. And are you able to say whether we've been able to find things we wouldn't have found otherwise yet, or again is that part and parcel of this evaluation work?
Yeah, that's so what we're looking at as the main outcomes in this study is how many of these polyps we detected in the people without the device and how many we detected it with. It's pretty much as simple as that, and if that number's bigger in the number with the device, that shows it's better than detecting than the naked eye.
And what kind of feedback have we had from patients when they have taken part? Have they been able to feedback about how they felt about being part of it?
Most have been pleased to be part of it, yeah. People comment and say that they like to be part of research. Patients like to be part of research. So I think generally, Ingrid may say more that they have a positive experience.
So we do what they call PRES, which is a patient research experience surveys. So we did do PRES sort of, for example, in COLO cohort before the pandemic and got really good positive feedback. We did have to change COLO cohort slightly because of the pandemic about reducing face-to-face contact between delivery staff and patients. And we continue to do PRES afterwards. So again, we got some really, really positive feedback from that. And it's a little bit like friends and family surveys type of thing. And we do listen to what our patients say. The vast majority of people who take part in research find it a very positive experience.
That's really good to hear. And this is one use of AI. Having worked with it at close quarters, how do you think it could be used in other ways, or do you think there's other ways it could be developed as part of your work to make a difference?
So I think there are lots of ways AI will be studied and used in medicine. I think it will transform medicine like few other things have. Just from there are lots of different ways used for analysing data. I mentioned earlier that we're looking at the microbiome. One of the things about the microbiome is there are millions and millions of different bugs in the gut. Analysing that data is pretty labour intensive. AI can do that much more quickly. So AI can be used to look at data. It can be used for things like detection, for imaging. It's very good at picking up patterns in data or results. So AI will be, without question, a major tool used by medicine in the coming years, without question. I think a very important thing to say about our research is the research that we've done so far has had a significant impact. So I mentioned earlier that we've led some of the largest endoscopy trials in the world. The impact of those has been significant. The Endoscopy vision device that we studied, we did the first really large trial showing its benefit. That change informed NICE practice, it changed NHS practice, and use of those devices went up from around about 1,500 a year in the UK to about 70,000 a year. So our research has a real impact. We tend to publish our research in really high quality journals and make sure people see it. So whatever we find from COLO-DETECT, we will make sure that the message gets out there. Hopefully it will show that this improves detection, but if it doesn't, that's equally important, because what you don't want to do is waste resources on things that don't help if they don't help. And we have done negative studies before. We did one called Discard 2, which is around telling a difference between different types of polyps, and we did a large study, 2,000 patients, and we showed that it didn't work. So that is equally important. You don't want people believing something works if it doesn't.
That's really interesting. And I guess as we're talking about kind of Cancer Month, what advice would you give to anybody about their diet or their well-being or lifestyle that you think would really make a significant difference? Or, you see patients who have the same lifestyle that end up coming to us and we look at them. What advice would you give to your friends and families, I guess?
So we know that there are some things that we can't change, like family history and male or female in terms of risk of bowel cancer, but there are some very well-known preventable factors. So they are obesity. Obesity makes people far more likely to get colorectal cancer. We're doing some research, we're hoping to do some research which we've applied for funding for, called COLO-LIFE, which is about addressing obesity. We know that smoking increases your risk of bowel cancer. We know that alcohol increases your risk of bowel cancer. We know that not eating enough fruit and fibre increases your risk of bowel cancer, and we know that eating too much red and processed meat increases your risk of bowel cancer. So those are the main areas that we can address. And there's something called the World Cancer Research Fund, which has a really good table of the things you can do to reduce your cancer risk, and those things feature really highly on that.
Good, great. That's a guidance for us all, I guess. And because we really want people to join our trust, we're a great place to work, and we want people to come and play a part in our future and furthering things like our research. What difference have you seen your work make to our patients? When you sit back and look back, what kind of satisfaction do you get out of your role?
Well, I think Professor Rees has mentioned there about the results of the adenoma trial, and adenoma trials which introduced the use of the endocuff vision. So that's sort of common practice now, and that's certainly helped outcomes from colonoscopies. I think as a research active trust, it's very appealing. Having worked in a different trust before I came here, so you had a little look at what they were doing, and had a chat with different research colleagues, and it was very appealing to actually come here, to work here and be part of this trust. Professor Rees just mentioned before, some of the work done around the microbiome, it's not just sort of recognised locally, it's not recognised nationally, it's actually globally. So it got some really good feedback from one of his colleagues who's actually based over in Australia about the world-class research that we're doing, and that's just amazing to be part of that team that's doing this recognised world-class research. It's amazing.
So we're not just making a difference to our patients, we're making a difference to patients, full stop.
Yeah, I think research means that we're trying to find the best care for patients and deliver it to them. I think that research also means that people up their game. So I think in a research active department like this, it makes people be up to date with what's newest, what's most current, so I think our patients get better care for that reason. I also think it's very important for recruitment and retention of staff, which is obviously crucial to delivering good care to patients. You know, we're known as one of the leading gastroenterology units in the country because of our research. We have no difficulty recruiting staff and retaining staff. We have people falling over themselves wanting to come and join us. So I think that kind of reputation is really important, and our patients benefit from that because they then get those good high quality staff delivering care to them locally.
And it must just make a difference to you knowing that you're helping to save lives and
Yeah.
will do for generations to come. That must just be a huge sense of well-being and satisfaction in your roles.
Yeah, I think the whole of medicine, it should be an inquiring specialty. You know, don't just assume. We assumed years and years ago that whipping kids' tonsils out was the right thing to do. It actually wasn't. You know, there's very specific indications that you should do tonsillectomy for. So really, whatever we do, we should always be questioning it and actually saying, is this the right thing to do? Is it the best for our patients? Is it the best for their care? And is it cost effective? Is it the right use of resources? So I think having that questioning mind is really important, and that's what all of our team have, and I think that means that we continue to deliver the best care for our patients.
Colin, would you like to give the team a shout out, because I know that they work exceptionally hard and we wouldn't want to go without recognising their efforts.
Yeah, so we work with an absolutely fantastic research team here. I mean, I can't name everybody because the whole of the endoscopy department are research supportive and active, but Zoe Clapham and Diane, the endoscopy managers, are hugely supportive of research. But within the actual research team themselves, Claire Livingston is our manager, Amy Burns, Ingrid, Emmerson, Jill Effrey, Sarah Manning, Laura Nielsen, Alexander Sager all do a brilliant job in supporting our research. There are others that I've forgotten to name. Nathania Beswick is one that comes to mind. Paula Madgwick. I should mention Professor Linda Sharp, who's Professor of Cancer Epidemiology at Newcastle University, and Professor Mark Hull from Leeds, who work with us very closely on the COLO-SPEED programme of research. These are people who do a brilliant job, so we're really grateful to them.
And I guess they form part of our bigger hospital network, which just makes everything run smoothly.
Yeah.
All the people we work alongside outside in terms of admin and domestics and all sorts of stuff, we couldn't do, or you couldn't do the work that you do without everybody playing their part.
Absolutely. And probably just one maybe last thing to mention is that we, as a result of our research, we've won multiple national awards, and I think that's great because that really affirms
I think that
the
deserves
team.
a shout out. Yeah.
We've won the Health Service Journal Award, which is considered probably the leading research award in the country. We've won the Royal College of Physicians Excellence in Patient Care Award, and we've won multiple awards for specific trials. We've probably won around 10 awards over the last 5 years, pretty much all of them nationally.
And hopefully more to come.
Hopefully more to come.
Sounds like a really good point to close on. So thank you very much to Ingrid and to Professor Rees. Thank you for joining us today.
Okay, thank you.
Thank you.
Thanks for joining us for this episode of Our People podcast. We hope you enjoyed it and check out our other stories. Hit subscribe to keep up with the latest and catch up with what we've been up to on our Twitter, Facebook and Instagram pages. Just search for our name.